It's April 25, 2025. This is the Rheum Now podcast. Hi, I'm Jack Cush, executive editor of rheumnow.com. This episode is going to be called Rheumatology's Believe It or Not. Ripley is on vacation, and I'm here. Why am I choosing that? Well, we got the Trinetics database giving us data that's going to be interesting. We've got network meta-analyses and other meta-analyses and systematic reviews sort of cracking some of our beliefs. And we've got a review of guidelines that kind of let us believe our guidelines are kind of behind the times. Let's get into it. A retrospective study on EGPA looks at what we should do when treating EGPA with mepolizumab, and can you change the dose? Now, I like this because it brings up an interesting clinical option, although the data is based on 45 patients. So this really kind of needs to be studied. Basically, these are EGPA patients treated with mepolizumab and doing well at the initial starting dose of 300 milligrams every 4 weeks. And then some of them, a quarter of them, switched to 100 milligrams every 4 weeks, and that was done after 2 years of doing well. So what happens when you lower the dose, basically your maintenance dose, of mepolizumab, or if you continue it? So it turns out that 50% of these patients who lowered their dose were able to maintain complete remission without the need for other additional glucocorticoids. So it's a small sample. The other half who got worse, they got worse in a minor way, with mainly upper respiratory sinonasal symptoms that were either treated with local therapies or going back to the initial dose of mepolizumab. I think it's something that should be studied. IL-17 inhibitors, as you know, increase the risk of IBD. And may be contraindicated in patients with IBD. The Trinetics database you see a lot of these. I report a lot of these. It's a linkage of, many, many hundreds of thousands of electronic medical records nationwide, worldwide. And they find large populations, and then they do propensity matching to sort of normalize the data and make it more respectable. But supposedly there's a lot of variance in how the propensity matching goes on. So not all of this great high number cohort data on things you usually can't study is going to be always perfect. I think you have to know a Trinetics expert to know how this one was done. And I'm not a Trinetics expert, but I'm reporting that in their analysis of patients who have either psoriasis or ankylosing spondylitis, who were either started treatment with an IL-17 inhibitor or with a primolast, and they looked at what happened to them downstream. So in their hundreds of thousands, they found 13,000 that they matched up in each treatment group, and then they followed them. So that's like 26,000 people. 142 developed IBD with IL-17 therapy, and 60 with a primolast, giving the clear-cut edge to a primolast or an increased risk of IBD with the use of the IL-17 inhibitor. The adjusted hazard ratio here is 2.5, a 2.5-fold increased risk. Now, there's a selection bias here, right? These people, even though they match them up with propensity matching, those who choose to go on a primolast versus the IL-17 inhibitor, different. You don't use a primolast in ankylosing spondylitis, right? The risk of IBD with psoriasis and ankylosing spondylitis with the IL-17 inhibitors is significantly higher with in the spondylitis patients, because they have that subclinical ileitis thing and just waiting to bust out and become overt IBD. So anyway, this data does support the current clinical contention. I'm not sure about the strength of evidence, but I put it out there for you to consider. Another IBD related issue is not IBD, but in this case, gastrointestinal perforation, which you know is a risk of using IL-6 inhibitors, but also JAK inhibitors. It's in the warnings for both compounds or the multiple compounds under those two classes of drugs. This particular study was a network meta-analysis of 23 clinical trials with over 20,000 patients, followed at least for 24 weeks, looking at the incidence of when you start a JAK or a conventional DMARD, the incidence of developing gastrointestinal perforations. Those are usually lower, but they can be throughout the GI tract. The incidence here was 0.19%. That's pretty low. The numbers, I think, in the package insert for the IL-6 inhibitors is like 2.6 and 1.9 per 100 patient years. So even though that's a different way of accounting, that's kind of similar. But in this pairwise analysis, again, a network meta-analysis, they showed that if you were on a JAK inhibitor, you had no higher risk compared to those that were on a conventional DMARD. So the relative risk was 1.02, not significantly increased. You know, I have a little bit of a concern about network meta-analyses. They always seem to show the point someone wants to make. And you are trying through statistics to compare apples and oranges, meaning these are not patients that are in the same trial. These are patients in different trials in different countries wearing different shoes, enrolled for different reasons, but they put them together because they meet entry criteria and they normalize the outcomes, whether it's a safety or efficacy outcome according to what goes on with placebo. But in this case, they say there's no increased risk of gastrointestinal perforation. When I would say, based on the package insert warnings and claims data analyses done after these drugs were approved, IL-6 and JAKs, there really still is a warning. But to their credit, I would say I treated a ton of patients with JAK inhibitors, and much more so than with IL-6. And I've had one GI perforation with IL-6. I've not had any that I know of with JAK inhibition, and that's just my own personal experience. And a 1 means very little. I like large number data. So think about that and whether this colors your thinking. Of course, you don't give the IL-6 or the JAK inhibitor people who have a history of diverticulitis, not diverticulosis. Diverticulosis is fine. Diverticulitis is at higher risk for gastrointestinal perforation, especially if they're on steroids. That's a contraindication to the use of those two drug classes. Who knows if that was in play in this network meta-analysis? It probably was, because they use clinical trials. And people enter clinical trials under the most stringent of conditions. Another interesting meta-analysis is coming up, I guess. Let me just do that right now. Meta-analysis of methotrexate in knee OA. What? I did a trial of methotrexate in knee OA, not inflammatory OA, knee OA. I did that as I left Southwestern in mid-1990s. We enrolled 20, 30 patients. The initial data cut looked encouraging, but in the end, it was not significant. I never wrote it up. But there have been a number of trials, and we reported them here, and most of you don't believe the data. And I'm kind of with you. The good news is methotrexate's safe. The bad news is we have no disease-modifying therapy for osteoarthritis of the knee. So in this meta-analysis, they found 6 trials that met their entry criteria, a total of 602 patients who were enrolled to either receive methotrexate or placebo looking at knee OA, not inflammatory knee OA, knee OA. And they showed a significant improvement in pain with a mean difference of minus 0.44 that was highly significant, P and 3 zeros and a 3. And that was for relief of pain with either hand or knee OA. So they did have some hand patients in these trials. The functional improvement was only seen with knee OA, but there were no differences in the two treatment groups with regard to quality of life outcomes or adverse events. Are you using methotrexate to treat knee OA? Why would you use methotrexate to treat knee OA? We just need really well-designed, larger trials to know that this is the thing to do. Today I was teaching a bunch of students about scleroderma management, and I had an old slide that said there was no role for methotrexate, and I now know that that's not true. Methotrexate is highly effective in localized forms and maybe linear scleroderma. In the diffuse form, not so much. Okay, at least looking at the major outcomes. But looking at skin outcomes with linear or morphia, very, very good. Good data by Heidi Jacoby at UT Southwestern. Let's get back with another interesting study about the risk of developing lupus and what increases your risk. Guess what? Worry is something to worry about. Systematic review of PTSD and its link to lupus onset shows in 7 studies, 5 of them prospective cohorts, 1 a retrospective, 1 case control study, 11,600 SLE patients that 11% of them had a history of PTSD as a comorbidity. This was mostly in females, but then again, we're talking lupus here. I don't know what that means. All these studies showed an association between PTSD and lupus and developing lupus. Okay, and in 3 of them, they showed a 2-fold increased risk of developing future lupus. They looked at a number of other factors. I mean, is there a genetic connection here between PTSD? And they did not find that. And there's a lot of data about stress inducing the disorders we take care of, including rheumatoid arthritis and lupus. PTSD, maybe the best characterized form of stress out there. We still don't know what we don't know as to what causes lupus and these other disorders. My best guess and my best advice is avoid the PTSD, all of those letters, avoid stress, and if you can tell me how to do that. Interesting thing about stress, I use a survey form in all my patients when I see them, and it asks them about things that they are experiencing. Are you working? Are you exercising? Do you have these? Review of symptoms. And I had one question on there for a long time with, what is your current stress level? Every patient, everywhere, under all circumstances, wrote high. Everybody believes they're under stress. And I don't know how true that really is. I believe that you either get stress or you give stress. So I aim to be the guy that gives stress. Sorry about that if I've done that to you. A nice review on pregnancy and reproductive health guidelines and the use of DMARD therapy. And I guess the purpose of this, I say, why did they do this? We just had the ACR guidelines on reproductive health, which were incredibly comprehensive. I know that. I was on the committee. I think that Lisa Samaritano did an incredible job of looking over tons of information with a really expert cast of pregnancy autoimmune mavens, including representation by maternal fetal health and other specialties. And why did they do this? Well, they actually reviewed 18 current guideline recommendations for use of DMARDs, either with pregnancy or as it affects reproductive health. They found that the recommendations were quite heterogeneous, that they were all over the map, that only about half of them addressed preconception and conception, 2/3 addressed lactation, 1/3 only addressed male fertility. When it came to the use of conventional DMARDs and biologic DMARDs, 3/4 or 72% did, but only 28% addressed targeted synthetics, meaning JAK inhibitors. So overall, they found that the recommendations regarding the use of conventional DMARDs in pregnancy, either prior to or during, were pretty well covered, but not so much for biologics and targeted synthetics. And I know that that is covered in the ACR Lisa Samaritano A&R piece that you should have in your desk and refer to when this comes up. They're concerned also about how we advise males and the use of our drugs and how that may affect fertility and conception as well later on. We've discussed that in the past. Hip replacement is not linked to OA severity as far as the outcomes of hip replacement. So OA severity might get you hip replacement, but what happens after you have hip replacement surgery, as far as your mobility and your recovery, is not related to the severity of the OA. It's actually related to muscle mass prior to the hip replacement surgery. I thought that was brilliant because I think that was the key to my success with my bilateral knee replacements. I worked really hard on leg strength, lower extremity strength prior to my surgery, and my recovery was great, really great. So what they showed was, and this is a small study, it's 10 patients who they did imaging, MRI imaging, looking at muscle mass and damage and whatnot, and they showed that it is muscle quality that best predicted recovery after surgery. So that should be your guidance to your patients. The best thing you can do for a patient undergoing hip or knee replacement is prehab. Send them to rehab to strengthen their extremities before they have the surgery. Even if they're really obese or really out of shape, it's going to help them tremendously. And then I think that everybody that has joint replacement should have a rehab program, a serious rehab program that sometimes the orthopedists don't want, but that you should push for. A retrospective study by David Sherry in Philadelphia, who does a lot of work on pediatric fibromyalgia and pain disorders. He did a retrospective study of 334 children who had non-organic amplified musculoskeletal pain syndrome. That's called AMPS, amplified musculoskeletal pain syndrome, with back pain. And they just showed that those who had localized back pain were more likely to have a positive straight leg test, meaning there's organic pathology in the disc and spine and nerve, right? And that was significant. But whereas diffuse amplified musculoskeletal pain in kids with back pain was more likely to have allodynia and a few other features, including what they called an incongruent affect. That's where they report pain, but they're still cheerful and happy, and there's a disconnect between what you see and what you hear. Yes, this all sounds like fibromyalgia. I think it was an interesting article. Another interesting article on obesity as a risk factor for not achieving remission. This is a cohort study of 1,285 early RA patients, a really strong prospective study. And they looked at those who did not achieve remission. Remission failure at 6 months was highest in those who qualified as obese by BMI, 64% if you were obese, 52% if you were just overweight, and 48% if you were normal. So if you had normal weight, you had a 50% chance of not achieving remission, 50% chance of achieving remission if you're normal weight. But it's 1/3, 2/3 achieving remission, not achieving remission if you have obesity. This did not change after they adjusted for seropositivity, education, smoking, alcohol, physical activity. Again, obesity, a bad player. I want to see the data about newer obesity drugs and how we're going to be using them and what their effects are. We know people do better in the RA, gout, lupus outcomes. We know they have less cardiovascular events. But can you be using these more purposefully to get obesity off the table so you can better manage your patients, whether in this case RA, early RA for that matter? I like to report this week about increased neutrophils in RA synovium correlates with higher disease activity and poorer response to conventional therapy and biologic therapy. So you don't generally think of the rheumatoid synovium. The rheumatoid synovial fluid is just chock full of polys, right? It's kind of like the sink or the toilet, if you will. And that's where the polys will accumulate and then ultimately contribute to damage to some extent, but not as much as that which is in the synovium. In the synovium, we know it's largely mononuclear cells that are driving the bus, that are causing the damage, along with the fibroblasts. But in this study of 55 patients, a third of them had enrichment for synovial polys, neutrophils. And when they did analysis of those who had polys that were enriched and did not have polys, the ones who had polys had more synovial inflammation. They had higher -28 CRPs. They had more CD3, CD68 cell counts, also contributing to the inflammation and damage. It's a different subset. So the things I'm worried about in RA, not managing the fibroblasts and stromal cells that are causing all the damage. Our therapies do nothing for that. Our therapies generally do nothing for polys in synovium. These are other avenues that need to be explored going forward. A patient with RA is doing well on a TNF inhibitor and methotrexate. What do? Well, a study from China looked at 84 patients who were doing great on certolizumab and methotrexate, and they randomized them, open label randomization, to either continue on the double therapy or to stop methotrexate and just stay on certolizumab. And what do you think happened? Yeah, the patients who were doing well after you stopped methotrexate, they still did well. It was 85% achieve remission or stayed in remission, remission, low disease activity state on certolizumab and methotrexate versus 84% on certolizumab alone. But if you stop methotrexate when on certolizumab alone, you had less GI symptoms. So this is actually something that we probably should be doing. And there are other studies that have suggested this. This is different, though, than patients who are doing well. And there's a Japanese study. I can't remember it. I talked about it 5-7 years ago, and it was backed up by another Japanese study. Patients on methotrexate who are not doing well. And then you put them on a TNF inhibitor. What happens if you leave them on both drugs, or you stop the methotrexate and just put them on the TNF inhibitor? And it was done with etanercept. If Artie Cavanaugh was here, he would remind me the name of the study. The study showed that you should continue the methotrexate, and that gives you significantly better responses. So adding on is different than taking away. Think about that. 2 more reports I think that were impactful this week. Better responses with baricitinib when you gave it at night. What? This is called chronotherapy. I don't know what you tell your patients. Some patients take the drugs at night. Some take them in the morning. I tell my patients to take it in the morning, get it over with. I don't like it when they take it at night. But this data, a 1-year study, it's non-randomized. It's open label. It's a few different regimens being compared. And 122 patients treated with either 2 milligrams a day or 4 milligrams a day of baricitinib, and they either took it in the morning or they took it in the evening. So there's 4 treatment groups here, right? Now, you got to worry about it being non-randomized and open label, right? That kind of screws up any claims to fame here. But we're looking at ACR20 outcomes. The groups were fairly well balanced. In the end, baricitinib 4 milligrams given in the evening was significantly better than baricitinib 4 milligrams given in the morning. 78% versus 43% ACR20s. What happens when you use baricitinib 2 milligrams in the morning versus at night? Night was numerically better, 76% versus 61%, but that was not significant. But it was significant at certain time points at 4, 24, and 52, and ACR 50 at 4 and 12. So it was kind of spotty. Numerically, it was higher, and at times it was significant. So I think this is smart because one of the main things, hard discussion to have about what baricitinib and JAK inhibitors are doing biologically, but everyone agrees that one of the mechanisms is that it is lowering IL-6 levels. IL-6 is clearly a cytokine that is produced in a circadian fashion and peaks at night, late at night. Okay, so giving baricitinib and other IL-6 inhibitors at night is what you do. In my Stills patients who are going to take IL-6, I tell them take it at night for the IL-6 effect. In my Stills patients who are going to take IL-1 inhibitors, I say take it at night because IL-1 is also a circadian cytokine that's peaking late at night, and anakinra only has a half-life of 6 hours. Take it at night. Chronotherapy is something we need to see more of, and you might want to experiment with this while we wait for a better trial to prove the point. Last bit of evidence is you can prevent diabetes in almost anything by using hydroxychloroquine. This is a study of patients with primary Sjogren syndrome coming from Taiwanese insurance claims data analysis, looking at 4,800 primary Sjogren's patients on hydroxychloroquine versus 2,400 not on hydroxychloroquine. By the way, why are these patients with Sjogren's syndrome getting hydroxychloroquine? I know you do it. It doesn't work. It's never proven to work. The guidelines and the review of guidelines on this have said that over and over again. But some of the guidelines, even despite the evidence, say, go ahead and use it for musculoskeletal complaints or pain. It does nothing to dry eyes, dry mouth. Okay? Anywho, that's my bias. But this study was about prevention of diabetes. 4,800 versus 2,400. 500 patients developed diabetes after an average of 5 years. If you were on hydroxychloroquine, you prevented diabetes, and it did so in a dose-dependent fashion. So less than 300, 151 to 350 milligrams a day, was a 40% reduction. That was significant. Hazard ratio 0.6. If you were on more than 350 milligrams a day, it was a 67% reduction with a hazard ratio of 0.326. As you might expect, patients on glucocorticoids had an increased risk of developing diabetes. And these are almost all type 2 diabetes, right? With an 83% increased risk. But if you were on high-dose hydroxychloroquine and you got high-dose steroids, you still had a lower risk of developing diabetes, and it went down 37%, and that was significant if the hydroxychloroquine dose was greater than 350. Again, there are so many reasons our patients should be on hydroxychloroquine for all our diseases, lupus especially, but even in RA and Sjogren's and wherever else it may have its benefits. I want to go back to this report about lupus and PTSD. I was going to save that report for next week because next week, Rheum Now starts a campaign on lupus. It's called Unlocking Lupus. You have the keys to mastering control of lupus. You're going to be shocked at the amount of volume we have of great reports, great contributors. I've been working on this with an advisory group of the world's best lupus experts, and what we've got coming up starting May 1st and throughout the month of May is really going to be great. It's going to be sponsored by Aurinia, thanks to them, and I think it's going to be a great learning month as far as lupus. And by the way, May is Lupus Month. That's it for the podcast. Tune in next week. Follow us on Rheum Now. Give us a good rating if you're inclined to do so. Thanks.